Tom Carell. Tom, it's lovely to have you on this program, just right for the CEDAR input and what I regard as a great advance in imaging, and for you to personally give this. Now, for those who don't know, Tom's a distinguished vascular surgeon and symptometrist and was so interested in this subject, he devoted his life to it recently. Tom, take it away. Thank you very much.
So thank you very much for the invitation to speak today. These are my disclosures. What I want to talk about is how we plan, navigate and review cases today, our vision at CXAortic for what we call intelligent planning, and the progress we've made to making that vision a reality. When we plan today, we tend to use standalone software and generate a piece of paper or PDF that has measurements, notes and sketches on it. We then come to operate. We essentially memorize that plan. We may stick it to the wall in the operating room, but we really rely on our mental ability to be able to match that plan to the fluoroscopy imaging on the screen and to mentally interpret how the anatomy has changed with stiff wires and delivery systems, and also to mentally adjust that plan for this distorted anatomy. When we come to review, we have the CT scans, pre-op, post-op. We maybe review the plan itself, fluoro images, but essentially we qualitatively assess the outcome. And the learning experience is very much a local one for those in the multidisciplinary team in the room. Our vision for intelligent planning is bringing all of those capabilities together such that each new case is informed by all previous similar cases globally, not just locally, and each new case contributes to the planning of all future cases. This concept should be familiar to us because essentially every navigation app we use does this, where your journey is informed by people who have taken similar journeys in the past, and in turn informs people who may make similar journeys in the future. What does that look like in endovascular surgery? Well, it starts with a patient-specific search of the data pool, where you're looking for patients' similar anatomy and the actual repair outcomes that they've had, both anatomically and in terms of the measures of success. The physician selects the preferred option, and an operative plan which consists of a map and the expected deformed anatomy is generated. When we come to do the procedure, that map is overlaid on top of the live fluoroscopy with millimeter precision, and it updates for the deformation during the course of the case, and information is presented in the right time, right place throughout. When we come to review, all of that information is together, and in addition, the team is presented with quantitative metrics in terms of the technical result of the procedure. And it's referencing the patient outcome data, so it allows the team in the room to make informed decisions specific for that patient as to what follow-up they need, and that's backed by evidence. The progress so far, the cloud platform is in place. It's in routine use in 6 countries, over 2,000 cases to date, and regulatory clearance, including for information security and data protection. It generates maps from CT scan, a lot of AI in this, mostly around simplifying user workflows, but also with virtual wires in there that are used to deform the anatomy later intraoperatively. So version this with full planning capability that is due for release in the coming months. When we come to navigate, it's the computer vision, which we call image tracking. So there's no tracking of any hardware in the operating room, just looking purely at the fluoro. Millimeter precision, really high confidence. Yellow overlays the preoperative anatomy, blue overlays are the modified deformed anatomy. And it's been shown to reduce radiation exposure and to shorten procedure time. So what we're working on now are the ability to be able to classify each patient according to the configuration of preoperative anatomy that they have, curvatures and diameters, and the disease burden, and obviously to be able to search the pooled database for similar patients. We're also augmenting the navigation intraoperatively with a full interactive plan on screen and the display of contextual information. And we're also developing review metrics that will allow you to have some quantitative measures to assess the outcome of the patient to help you with the risk stratification when deciding on follow-up. So to finish, just to say that this space is incredibly exciting. The promise of the AI, it's real, and it's all about increasing the amount of information that you have available and in a way that you can digest as a human and make human decisions. And the stuff is evolving incredibly quickly. If you'd like to find out more, do get in touch and look forward to answering any questions. Thank you for your attention.
Well, Martin, can you get all your data over to him? Is that?
Martin, that's a question to you, I think. Martin.
Yeah. Say it again. I have trouble understanding the question. Can you repeat it?
Well, he's collecting everybody's data here to make changes. Can you get all that data over to him? How does this translate to what you see in the lab?
Let's let Tom talk about that. Yeah. Tom, that up, please.
Yeah, exactly. So we don't harvest any. No one kind of pushes data to us just simply for the purpose of interpreting it. At the moment, it's the data that gets processed during standard use. The data that we get to develop our enhanced capabilities with is all anonymized data that comes out from the agreements with the hospitals that we have around it. And really, it's just it's training the neural networks on the 3D data from the CT scans, and also on the 2D data from the fluoroscopy images captured during the procedure. And the deep learning, these simulated neural networks turn out to be very good, extracting numbers effectively, classifying the images that you've got. And that's what we're trying to do, is present those numbers back to users in a way that helps them make decisions that are more specific for that patient.
Well, I think it's brilliant. Now, I think so does Jan Heiligers from Tilburg. Can you give him that question, please?
Yeah, we have a question here from Jan. What part will be the main focus plan? Perform or analyze?
So actually, well, we hope to complete the whole circle. So the steps to it, the next step that's being released is the preoperative planning and the ability to be able to give you metrics in terms of derived from the diameters and curvatures, so the cylindricality, how conical something is, and allows you to classify that patient and then find similar patients with similar anatomy. The longer term goal is to close that loop so that when you then come to look at a post-operative result on a patient, you can then get some metrics, hopefully ahead of the curve in terms of seeing diameter expand, as to whether this is looking like a durable repair or one that needs to be under enhanced surveillance and is heading towards a reintervention.
So it has implications in both. Yeah, sorry.
Sorry, I see a very high potential of this method in the post-interventional follow-up CT scans. Do you have any plans to use AI algorithms to learn how to automatically detect neck changes, enlargements, and migration? Is that also a plan of your project?
It's underway at the moment. It's underway at the moment. Yeah, exactly.
That saves a lot of radiologists' work time then, yeah?
So yeah, exactly. I mean, it's trying to take away the things that are time consuming and where there may be a lot of inter-observer variability, so that you can then have those shortcuts to it, so that you can use your human intelligence, which has its own advantages over the AI stuff. Brilliant discussion. I think that was wonderful. Personally, I think so orientated towards the surgical need. And this high quality imaging, as Alan's been telling us, and we've heard from you all, related to the surgical need is fantastic.